Good evening, everyone. Thanks for joining me tonight. It's good to have so many of you with us, and look forward to sharing with you guys the things I've been doing over the past 20 plus years. They've helped me be very successful with porcelain veneers. And the subject matter for tonight is something I get asked about a lot when I do live lectures. I end up spending an awful lot of time in these two areas because it seems to be a place where a lot of people are confused or not comfortable. So I thought I'd design this program tonight around these two specific areas and really focus on them, dive in a little bit deeper, in hopes to clarifying this part of doing veneers. And I get why people have a lot of questions here. It's if you're not doing a lot of veneers, it's a little bit different than your regular crown and bridge. So I get why there's some confusion or hesitancy on a lot of practitioners' part. So I'm hoping to clear that up tonight and give you some ideas to help make this more routine, more easier. Probably not a right word, but allow you to be more comfortable with these two parts of the porcelain veneer process. So temporization has always been a challenge. I've tried everything over 30 years. What I'll share with you today is what I've been doing for probably the last 15 or 20, and I found works really well. It's really predictable. And then also the cementation part, because some things have changed and some things haven't. But there is kind of a standard routine that if you follow it, you really shouldn't have trouble. So we're going to go over those in depth. I'm going to try to get done in time that I will be able to answer some questions at the end. Typically, I can't get through all of them. And the reason my email address is on this screen is you're welcome to send questions to that email address after the program. And I'll do my best to get back to you in a prompt manner and answer anything that I wasn't clear about. Okay, so since I didn't get an intro, this is kind of the stuff I've been doing for a long time. Mostly it just means I've been old and I've practiced a long time, is kind of what that means. But right now, I am behind that tree. That building behind that tree is where I am right now in my downtown Denver location. Except it's already dark here now. And everybody has to put in family pictures, so I've got a bunch of those. All right, let's get right into it. Veneer temporization. So for me, the most critical part about veneer temporization is the wax up. Now, everything I'm talking about would apply to one veneer or 10 veneers. But in general, I'm talking about veneers where you're doing 4 or 6 or 8 or 10, and you're doing those together. So the wax up is a critical part of the temporization procedure. One, because the wax up allows you to visualize the end result before you start. And that tells you where you need to prep, how deep you need to prep. Do you need a veneer? Do you need a 3/4 crown? Do you need a full coverage crown? It also allows for you to communicate with the patient and make sure the design you're thinking about is the same design they're thinking about. So for me, it's always one of the most critical parts about what we do is in the consultation, we're talking to the patient about what it is their chief complaint, but also what is their end goal. And by listening to that and having a conversation about the end goal, we use that information to communicate with the ceramist to create the wax up that becomes the template, the blueprint for what the final veneers will look like. So for the communication in the planning part, the wax up's very important, but it's also an important part of the temporization phase, because what I want to do when I fabricate the temporaries is to allow the patient to begin to have a visual idea of what it's going to look like when we get done. And that does a number of things. One, the temporaries many times address the chief complaint at the prep visit. Also, it allows for us to continue to communicate on the final design process. So the wax up is the ceramist's vision of my written communication of what we're trying to achieve. And when I use the wax up to make the temporaries, now I've transposed the ceramist's interpretation of my communication. I've placed it in the patient's mouth, and now the patient and I can look together to make sure that we're communicating on what end result we're looking for. Okay? And then the matrix, we're going to create a matrix off of the wax up that allows us to create the temporary so that we can have that communication with the patient to be sure we're all on the same page about what we're looking for in the end result. So this is a patient that we have prepared for 6 porcelain veneers, 3/4 veneers, depending on your definition. There we go. That's what I wanted. Okay, so this is the wax up that we created with the ceramist based on the patient telling us what they were looking for in the end result. Okay, so I communicate with the laboratory on the prescription form. This is the sort of design we're looking for. The ceramist creates this wax up. With this wax up, we sit down with the patient and saying, okay, if I'm hearing you correctly, this is the end result we're looking for, yes or no. Some patients can look at this and they can immediately tell you yes or no. Other patients are like, I can't tell until I see it in my mouth. Well, that's okay, because when we get to the temporary part, they will see that in our mouth. But for other patients, if they look at that and say, you know, not quite right, let's do this, that, the other, some things I can change in the office, other things I may have to send back and have the ceramist create those changes based on the patient's critique. Okay, assuming our wax up is what the patient is looking for, and 9 times out of 10 it is, with the wax up, I need to create this matrix. Okay, and this is just a putty matrix that's made off of the wax up that will be used to fabricate the temporaries. Now, the laboratory, and I've had many laboratories that do this for me, they'll create a Siltec putty matrix if you request it and send it back to you with the wax up. My experience has been, and I have no explanation as to why, when I make the matrix myself in the office, the temps always turn out better than when I have the lab make it out of Siltec. No explanation, just that's how it works for me. So in the office, I'll make the matrix using, there is a putty impression material. It's a little bit hard to find. A lot of companies don't make it anymore. This happens to be the Kettenbach material, which is what I use, and they still make this putty material. So with the putty material, you take 1 scoop of the catalyst and the base. You mix it together by hand, and then I form fit it over the wax up. And then what you're seeing here is after the putty is set, I pull it and then I reline it with light body impression material, and I seat it back on the wax up so that I can capture all the fine detail that's in the wax up, and so that detail is carried on through to the temporary phase. Okay, so this matrix is really important when you go to make your temporaries, because this is where you're going to take this wax up and you're going to put it in the patient's mouth for them to visualize the final result, but also for you to get an aesthetic looking temporary. Okay, so putty and pressure material first. I just press fit it with my fingers over the top of the wax up, and then I reline it with a light body impression material. Just set it right back on top of the wax up, let it set, and then I'll trim it up with a scalpel blade to get rid of some of the bulk. And then the other thing I do that's not shown here in the picture is I actually take a Sharpie and I'll indicate the midline and the height of both canines so that when I go to seat the matrix, it helps guide me right into place. Okay, so we've got the wax up, we have the matrix that we've made, and then we have our temporary material that we're going to inject into the matrix. Before we do that, though, okay, your impressions are taken, your photos are taken, your bite registrations are taken, everything's done. Now you're ready to do the temporaries. What I do here is I take a little bit of phosphoric etch and I put it dead center on each tooth. I don't cover the tooth with etch. I don't need that. Okay, just dead center. Follow my cursor. Dead center, dead center, dead center. Okay, just a spot of etch in the dead center of each tooth, and I let that sit for about 30 seconds. After 30 seconds, I rinse and dry. Now, here's where one question comes up. Everybody wants to put on bonding agent. Do not put on bonding agent at this point. If you put on bonding agent, you're going to lock your temporaries in. They're going to be really hard to get off. You may not get them all off. It'll affect the final seat of your veneers. Okay? That little bit of etch gives you some micro retention to your temporary material. You'll get some mechanical retention interproximally. So these temporaries will be locked into place. Okay? So, to repeat, spot etch, dead center of each prepared tooth, rinse and dry. Now, take the appropriate shade of your temporary material and load this matrix just like you would any other preoperative matrix for a crown. Okay? So in this case, Luxitemp material, probably the B1 shade, load all this up and seat it to place. All right, if you're doing screenshots, after the impression's taken, I'm going to clean all the preps with plain pumice. I'm going to spot etch dead center of each tooth. That'll be for 30 seconds. Load the matrix with the temporary material, seat it to place, and then I let this sit for about 5 or 6 minutes. Now, most of our temporary materials are going to be set in 3 or 4 minutes. I let this set a little bit longer because if you let the setting process, the auto cure process of the temporary material take place a little bit longer, it sort of shrink wraps around the tooth. It binds a little bit better to the veneer prep. So I let it sit just a little bit longer, and it also allows it to get a little bit harder, which makes it easier to trim. Okay, so matrix in place 5 or 6 minutes, then we remove the matrix. And when we remove the matrix, this is what we're left with. This matrix fits so intimately that all you're left with is a little bit of flash. And lots of times it's really easy to get this flash off just with a sickle scaler. Okay, so I'll remove what I can with a sickle scaler. And then I go back with a 16 fluted carbide and I just follow the margins. And I have electric handpiece, so I turn the RPMs down a little bit lower. And I'm just getting rid of this flash. Okay, just following gently around, just like I'm doing with my cursor here. And get all that flash off. Okay, so once I have all that flash off, my other favorite tool is a number 12 scalpel blade right here on top of the papilla. And I'll use that to carve off a little bit extra where it's hard to get in with my handpiece. But a brand new number 12 scalpel blade will actually carve off the temporary material. Okay. After I do that, I take a 30 fluted carbide and I start polishing the margins. And that's a relatively low speed. And I typically do it dry so I can see the margins better. And again, I'm just going through those margins, smoothing off the temporary material. And then the last thing I do on the facial aspect is I take a Profi cup and composite polishing paste and I polish these margins. Okay. So once I've done that, I've got nice smooth margins. I'm checking with my Explorer, making sure I've got no overhangs or excess and smoothing that down real well. Okay, to the lingual side, that's pretty simple. I'm taking a 16 fluted football shaped carbide and just using that dry, and from the backside, obviously using my mirror, just getting rid of all the excess. But because of the fit of the matrix, there's usually very little excess there. And because of the nature of veneers, there's not a whole lot of issue with contact. Yes, you do need to check your contacts, but the lingual cleanup is actually pretty quick and fast. Now, on the lingual cleanup, I do want to mention you do need to check the interproximal area on the lingual. And you want to be sure you get rid of all the temporary material back there. And that's another place where the number 12 scalpel blade and a carving motion will help open up that papilla area. Because in these papilla area, you want to get rid of the temporary material so that the tissue has an opportunity to breathe, to heal. If you have too much temporary material there, the tissue is going to be red and irritated and probably bloody when you go to cement your veneers. So that's going to make your job harder. So you want to be sure you make room in the interproximal area for that tissue to heal. So my rule of thumb is I need to be able to take an Explorer, pass it through the facial, and be able to see that Explorer come through the lingual, and then I know I'm done. And the other reason for that is in the post-op instructions, I'm going to be asking the patient to use floss threaders and get in between all the interproximal areas and do their best to keep it clean while they're in the temporaries for a couple weeks. So if you do your job right and the patient does their job right, when they come back in the temporaries, it should look like this. Nice pink, healthy tissue, no red irritated areas. The papilla have filled in. Okay. So I want you to notice this. This temporary veneer on number 11 actually had popped off. But the reason I keep this picture and I show this picture is this patient delayed cementation over final veneers for over 6 weeks due to personal issues. This popped off at 6 weeks, and then it became time. It's like, okay, now we got to put them in, right? But this is kind of my timeline. And I keep this to show you that temporary veneers, when done correctly, can look like this even after 6 weeks period of time. Okay. So just you need to take your time, make sure you do it right, pay attention to detail. But your temporary veneers can have soft tissue that look like this if you do a good job and your patient does a good job. Okay, so post-op instructions for the temporaries. 1, make them aware they can't floss. These are all locked into place. You have purposely not separated them because by not separating them, the retention is way, way better. Okay, so the patient just needs to know in the temporaries only, you won't be able to floss. But here's what we want you to do while you're in the temporaries to help keep the tissue healthy. So normal brushing, great. Floss threaders, show them how to use them. Cross your fingers. About half of them might actually do it. Water picks work really well. Toothpicks and other varieties of toothpicks can help keep these areas clean. So give them these sort of tips, the same things you do with a patient that has a bridge. Okay, share with them all the ideas on how to keep the interproximal area clean. The other important thing with these temporaries is you have a flat piece of plastic trying to hold on to a flat piece of tooth. We don't have a lot of retention here. So they need to be careful when they're eating. So what I tell my patients is the easiest thing to remember while you're in your temporary veneers, you can eat anything you want as long as it fits on a fork or a spoon. Okay, so I follow that up with, I don't want you biting into sandwiches, bagels, pizzas, anything where you're incising on your food to be able to chew it, because that incising motion can torque the temporaries and make them pop off. Okay, so if it fits on a fork or a spoon, you can eat anything you want. If you have to bite into it, now you're going to compromise some veneers and you may chip them off. So if you're careful, you shouldn't have any trouble eating. And then the other common question I get from attendees and programs is, do you make them a night guard or retainer or anything like that? Very rarely do I make some sort of occlusal protection. Unless the patient has demonstrated a lot of bruxism and wear. If you make the temporaries right, you adjust your occlusion correctly, you should not need any additional occlusal protection. If you are worried about it, there are temporary splints you can make. One's called a quick splint that will cover the anterior 6 teeth. They can wear that at night so they're not bruxing on your temporaries. I've used those on occasion. On other occasions, I've actually taken an anterior quadrant impression and fabricated a small Essex in the office that just goes from second premolar to second premolar. And I have them wear that at night. And that little bit of protection tends to help some patients. My point is, it's not really necessary unless you're dealing with a patient where you're seeing a heavy wear pattern, active bruxing, those sort of things where it makes you really concerned. But quite honestly, if you're doing veneers on patients like that, you probably are dealing with occlusal issues that need to be dealt with long before you get to the veneer phase. Okay, so that's temporization. Now, the other second most common question I get is, what do we do for delivery? Because there is a lot of confusion here. But quick summary is, and I'm going to show you this all in steps. Patient comes back for the veneers. We're going to remove the temps. We need to control the soft tissue because there's a good chance that you're going to have some areas of hemorrhage. So we're going to talk about that because that obviously needs to be controlled. We're going to clean the preps so that they are ready to accept the try-in of the veneers. Once we've tried in the veneers and the patient has accepted them and we're happy with the fit and the aesthetics, now we have to prepare the ceramic to optimize the bond strength of the ceramic to our cements. And we'll talk about the different cement options here. And then lastly, and as important as everything above it, is the cleanup part. So with removing the temporaries, I always start with a sickle scaler first, because the majority of the time I can engage the veneer underneath the papilla, and using a sickle scaler, I can just flick off parts of the temporary. And it doesn't come off in one piece, I promise you. It comes off in 10 or 15 or 20 pieces. But if you start in the interproximal area, you'll be able to engage the temporary, and you'll just flick it off to the facial, and a piece of temporary is probably going to go flying across the room. But that's, for me, usually the easiest way to get it off. And I warn the patient ahead of time, you're going to feel some pressure and you're going to hear some noise. You're going to hear some popping and breaking, but it's not your teeth. It's just the temporaries breaking. Sometimes, especially when I've opened up the interproximal area, I need to section the temporaries with a handpiece and a burr, going very slowly to make sure I don't nick my prep. But sometimes I'll have to section the preps to be able to engage the scaler to be able to pop off the temporary. So here are the temporaries on this patient I showed you earlier, just showing you where I engage the sickle scaler right at the tip of the interproximal area. But lots of times you'll be able to find just the tiniest little overhang, and you'll be able to engage right there. And with just a flick of the wrist, you'll pop off a big piece of the temporary material. Okay, if that fails, then I'm taking a carbide burr, usually a 16 fluted carbide burr, right here in the interproximal area, and I start my section right there until I can engage with the scaler right there and then flick it off. And then before you try in the temporaries, what I want you to be sure to do is take that sickle scaler using your loops, check right here where you etch the tooth. The other reason why I consistently etch the dead center of each tooth is I know where to look for extra temporary material, because your temporary material will bond better to that part of the tooth you etched than it will the rest of the tooth. So I'm checking with my sickle scaler right here, going back and forth, making sure I've got all the temporary off. And if you do this dry, you'll be able to see the difference between the frosty appearance of the temporary and the more glossy appearance of the tooth. So you're always checking right there to be sure you've removed all your temporary material. And then before I try in the veneers, I'm going to take some pumice, just plain pumice, and pumice clean my preparations. And when I do that, instead of using water in the plain pumice, I use a material called Hemoseal Inside. And this material has a number of benefits. One, it's a desensitizer. So it can help desensitize, help provide post-operative desensitization on the teeth. And two, it helps to disinfect the area because this material, this solution, has chlorhexidine in it and HEMA. So the chlorhexidine disinfection, the HEMA desensitization, and actually there is a little bit of research available that demonstrates the bond strength is slightly improved when you use HemoSeal inside. So instead of putting a few drops of water in the pumice, I put a few drops of the HemoSeal inside. But it's a very inexpensive material. And if it gives me 5% increased bond strength and it decreases sensitivity 20%, great. Why not use it? Some people ask, why would you use this and not Gluma? One, Gluma is definitely more expensive, but two, the glutaraldehyde component of Gluma, if you put that in a prophy cup and you start spinning the prophy cup at 20,000 RPMs, you're splattering glutaraldehyde all over the soft tissue. And as you know, glutaraldehyde can be a bit of an irritant. So you don't want to be splashing that around. Okay, so we've got the temporaries removed. We have cleaned the preps. Before we try in the veneers, we need to control any hemorrhage at the soft tissue because any hemorrhage obviously affects our bond strength. So we need that tissue dry and under control and ready for the bonding process. We have a number of different options here. We have hemostatic solutions, hemostatic paste, retraction cord, and a diode laser. Okay. When I'm delivering my veneers, I rarely use retraction cord. I use it when I prep. I use it before my impressions. But if you try to take retraction cord to control irritated soft tissue, my experience is the mechanical trauma of trying to place the retraction cord makes the bleeding worse and not better. Whether the retraction cord's impregnated or not, that mechanical trauma of taking your instrument and shoving a cord in an irritated area, I usually see the bleeding get worse and not better. So I don't use that. It is an option. I mention it only because it's an option, but to me, it's not a great one. For me, my first line of defense is a hemostatic solution, something like the Viscostat Clear. Now, the Viscostat Clear, the reason I like it is it's an aluminum chloride solution, not a ferric-based solution. Ferric-based solutions I avoid with anterior ceramics because I feel there's a potential for the oxidation of that ferric part of the solution to oxidize over time after cementation and could create a black or gray line at the margin. Aluminum chloride-based solutions, such as the Viscostat Clear, do not oxidize and create discoloration. So I always use a aluminum chloride-based hemostatic agent. So Viscostat Clear is just one of several on the market. So a majority of the time, 50+% of the time, this is all I need to control the hemorrhage of the tissue. However, there are times I need more than that. And when I need to go a little deeper in my tackle box, to control hemorrhage, now I look at hemostatic pace. So these are things like Expasil was the first to market 20 plus years ago. Traxident's been out for a long time, very popular. 3M came out 5 or 6 years ago with a very good retraction paste. But what these pastes do, and you can kind of see it down here if you haven't used one, they're in a carpule like your composite material. The tips are narrower, and you extrude this line of paste into the sulcus, and this paste, along with some retraction properties, the material expands after you extrude it. It's also, all these are impregnated with aluminum chloride. And aluminum chloride is the hemostatic we just talked about, so that will help reduce any hemorrhaging in the sulcular area. And then I bring this product up from Voco, which has only been out a year or so, but this has become my new favorite. Easy to use. I love the color. It's very easy to identify when you rinse it off, because what you do with this material is you set it to place, let it sit for a minute, maybe two, and then rinse it off with an aggressive air water spray. And the color of this material makes it easy to identify if you removed it all. I like the viscosity. And then down here, clinical example, we have excellent tissue control and we have excellent hemorrhage control. So a number of different products on the market. Some of these you may be familiar with. This is a newer one. Just happens to be my favorite, but I could use any of the ones I've shown you. And they do a really good job when my hemostatic solution alone isn't getting done what I need. Okay, so now we've removed the temps, we've cleaned the preps, and we've controlled the soft tissue. So now we're ready to try it. So now with the veneers, like any other indirect restoration, we have to try these into place to make sure we like the fit. And more important, or as important, is we have to like the aesthetics. And not only do we have to like them, the patient has to like them. So we're going to try in the veneers in such a way that we can evaluate them, but also in a way that the patient can evaluate them. So to do that, we're going to try in the veneers with a try-in paste. Okay, some clinicians talk about trying them in with water. The problem with water is there's no viscosity there, and we need a little bit of viscosity to help hold the veneers into place, because veneers have no retention, right? So we need something a little bit sticky to hold the veneers into place so we can seat the patient up, they can look in the mirror, and they can provide their feedback before we cement into place. And then we start talking about cementation. All the cementation kits that you're going to use for veneers, they should have a compatible try-in paste. Okay, and that try-in paste should be matched to the shade of the corresponding cement that you're going to use going forward. Okay, so here are these patients' veneers on the model. And then just a second, we're going to show you those tried into paste. So start the conversation on cements, and then we'll continue in a minute. But for porcelain veneers, I like using a light cured only resin cement. We'll talk about the reasons why in a moment. So in your light cured only resin cements, you should not only have your cements, but you're going to have compatible try-in paste with them. Okay. Some cement kits as few as 3, some cement kits as few as, or as many as 5 or 6 different shades. Quite honestly, 90+% of the veneers I cement with a translucent resin cement. So I not typically, every time I try and veneers, the first thing I try them in with is a translucent try and paste. So here you see these patients' veneers tried into place, held into place with the translucent try and paste. After I've taken my time to evaluate the fit and the aesthetics, now I sit the patient up and hand them a mirror and allow them the time to view these veneers and make sure they're happy with them. Because even though I look at them and it's like, these fit great, love them, ready to put them in, if the patient doesn't like them, everything gets put on hold. Why don't you like them? Give me your critique. Are these things we can change or not change? And we have to have that conversation, because if there's significant issues that the patient doesn't like at this point, I need to stop, make note of it, take photos, and I'm going to have to send the veneers back to have the ceramist work on these to create what the patient's looking for. Doesn't happen often, but probably a half dozen times a year, I'll get a patient in my office who recently had veneers done, who wants me to redo them because they don't like the way the veneers look, but the dentist never showed them the veneers before they cemented them into place. And that's a problem. And to me, ethically, if you don't show it to the patient before you cement them and they don't like them, I kind of feel like it's your responsibility to redo them, because you need to give the patient that opportunity to give you feedback. I think it's important, and is where cosmetic dentistry becomes hard. You can look at the work and think it looks beautiful, but if the patient doesn't, you've got a problem, and that problem's on your lap. So give the patient the opportunity to give you their feedback. I will not cement veneers into place until a patient has looked at them with the try and paste, approved them, and then gives me written consent to cement those into place. And my written consent is very simple. Paraphrasing, but I've been provided the opportunity to view my veneers before they're cemented into place. I am pleased with the cosmetic appearance and give Dr. Rads my permission to cement these into place today. Date, signed, witnessed. And that piece of paper is really important going forward, because if a patient doesn't like what you did a week from now, you've got something you can pull out of your back pocket and say, okay, well, you told me on this date you like them and now you don't like them. So where are we going to start the conversation? But it's just something to cover your tail from a legal standpoint, saying that, yeah, I let them look at it. They told me they liked it. I put them into place. And if they come back later, and it doesn't happen often, but it just has to happen once to ruin your day, month, or year. So just protect yourself when you're doing that. Okay. And when the patient's happy, you're happy, and then you get more referrals anyway. Okay. So we've tried these into place. The patient likes them. I like them. We're ready to cement them. Now, there's a process you need to go through to treat the ceramic before you cement the ceramic into place. So we need to clean out any contamination that's on the ceramic that was picked up during try-in, and then we're going to resilonate the veneers. So, back up. There's a number of ways that you can clean out the porcelain. In the old days, I would use phosphoric etch, and I'd put that on the internal aspect of the veneers for 30 seconds. And not to etch the porcelain, because phosphoric etch will not etch porcelain, but phosphoric etch is actually a really good detergent. So I would apply phosphoric etch, internal aspect, 30 seconds, rinse and dry. The other very commonly taught technique was put all the veneers in isopropyl alcohol in the ultrasonic for 90 seconds. Either one of these still works well. However, to make it simpler, manufacturers have come out with a very specific product designed for the sole purpose of decontaminating the internal aspect of veneers or crowns. So Bisco has a product called ZirClean, initially designed for the cleaning of zirconia, but also it does a great job of cleaning out the internal aspects of ceramic or metal. So you can use ZirClean. The other product on the market is called Ivoclean, Ivoclar, obviously, specifically designed to be used specifically with Emax, but can be used with any lithium disilicate. I don't care which one you use. I just would like you to, I wouldn't like you, I'm telling you, you need to use one of them. Because during the process of trying the veneers onto the preps, you're going to pick up contamination from saliva. Any bleeding that still may be present is going to get in there, get on your porcelain, and it will affect your final bond strength. So you want to decontaminate all of your porcelain so you can maximize the bond strength of your cement to the porcelain. So this is a really important step. So I've given you 3 different ways of doing it. Okay. Phosphoric acid, isopropyl alcohol in the ultrasonic, or one of these 2 products. But you need to do one of these 3 to decontaminate the internal aspect of that porcelain veneer. And then the next thing you're going to do is you're going to resilinate the internal aspect of the porcelain. And I say resilinate because my expectation from my lab, and I always clarify it with my lab, is when the lab sends me a porcelain veneer, they have silinated it in the lab. I expect that to be done from any lab I work with. But because of the try-in phase and the decontamination phase, I want to take the extra 60 seconds and spend another $2 to be sure I'm completely silinated the internal aspect of that veneer. The silination process is a very important part of the bonding process that ensures maximum adherence of your porcelain to the resin cement. So after I've decontaminated and cleaned the internal aspect of the porcelain, the last thing I do is resilinate the internal aspect of the porcelain. Now with silene, I strongly prefer silenes that are in 2 bottles because silene is a very volatile liquid. And these silenes that are in 1 bottle, I'm very concerned about the condition of the silene I'm using and how much is evaporated over time. Whereas in a 2-bottle system, such as the Bisco silene I'm showing here, you have fresh silene every time. 1 drop, mix it, place a drop in each veneer, spread it around a little bit with your microbrush, and then air thin it and dry it. And now your veneers are ready to be cemented. Okay, so for cementation, we need to isolate the area. We're going to acid etch it. We're going to use bonding agent, obviously, and then we'll talk about the cementation. The other important thing I left off on this slide is before I isolate, I go back with my pumice and the Hemoseal inside, and I clean the preps one more time. And after I clean the preps, I'm checking to make sure I've got no hemorrhage. And if there's any hemorrhage, I'm using my hemostatic solution or my hemostatic paste. And that has to be totally controlled before I go to cementation. Isolation can be with a rubber dam, frequently taught clinically. Not a lot of us do it. It's hard to do. I isolate using orthodontic retractors 90% of the time. Okay, in this case, because I wanted to be academically correct, I've got a rubber dam in place. I've cleaned all the preps. The tissue is all under control. There's no bleeding present. And I'm going to etch all 6 of these teeth because I'm placing all 6 veneers at the same time. So I'm going to place my etch on all 6. I'm going to let them etch for about 30 seconds, rinse and dry. And then I'm going to place my bonding agent. Historically, in the old days, a 4th generation bonding agent. This is just one example. That evolved to 5th generation bonding agents, another example. But for the last 5 years, universal bonding agents have pretty much been the standard. I've cemented all my veneers, literally all my veneers, with universal bonding agents for the last 8 years. And probably 90+% of them are with the All Bond Universal from Bisco. Okay, back up again. All right, etch for 30 seconds after I've rinsed off the etch. Place the bonding agent a good 30 seconds, and I'm just coating and soaking these teeth in the bonding agent. All right, you cannot put on too much bonding agent. Okay, so after a good 30 seconds of bonding agent, now an aggressive air spray. Okay, evaporate all that bonding agent and then 10 seconds light cure on each tooth. Okay, now I'm ready for the cement. Okay, so for the cements, I mentioned earlier, I like light cured only because your veneers are so thin, your curing light will pass through those thin veneers. Okay, so I don't need dual cure cements with thin veneers. Also, light cured cements give me a little bit longer working time. With a dual cure cement, once it starts mixing, the clock's ticking. And if you're cementing multiple veneers like I am here at the same time, you may get to that last veneer and your cement may be starting to set. So I've got better working time and I have command of my working time when I'm using a light cured resin cement. And I'll back up here just to mention this before we're going forward. As a side note, the other concern with dual cure resin cements is there is a concern in our industry about shade shift of dual cure resin cements over time. And there's some pretty good research showing that that shade shift still occurs. So until we see more research, by the way, look again in 6 months because you're probably going to see it. But until we see research that there is not shade shift in dual cure resin cements over time, I still like light cure resin cements where we know we have no shade shift. Okay, so certainly you can use dual cure resin cements. If you do, and you're doing multiple units at the same time, you need to move quickly to be sure your veneers are all in place before the cement starts to set. But be aware that this shade shift concern does exist. Is it dramatic? No. Does it exist? Probably yes. In the future, will that be eliminated? Pretty convinced by what I've seen. I just can't talk about it this time. So pay attention to what's going to happen in cements in the near future. But as of right now, today, 2023, I'm using light cured resin cements. Okay, so the etching, the bonding agent, talked about that. Light cure, the bonding agent, cements, lots of different cements on the market. This is Bisco's light cured, Dentsply and Kerr have light cure and dual cure options. Bisco has a dual cure option as well. Ivoclar, 3M, name your manufacturer that makes a resin. They make a veneer cement. But for me, again, the light cures, not to beat a dead horse, but I like the light cures for veneers as we are right now. Last thing to note on cements, and I want to be very emphatic on this. Self-etch, self-adhesive, dual cure resin cements are extremely popular right now, and they are great options for crowns. But for veneers, they are not an option right now. And these are just a few examples of the dozens on the market. Every one of these in the instructions for use will tell you veneers are a contraindication. And the reason for that is this category of materials, they do not have a sufficient bond strength to place a non-retentive restoration like a veneer and hold it onto the tooth in a predictable manner. So none of these manufacturers or anybody else right now that makes a self-etched resin cement will tell you can use it for a veneer. So do not, again, as of today, in 2025, it'll probably be different. But as of today, do not use a self-etched resin cement for veneers. Okay, now we're going to load our veneer with our light cure resin cement. We're going to seat it to place. Now I'm going to seat these one at a time. I'm going to clean off the excess cement, typically with just a cotton roll. And then I'm going to seat these all at the same time. At this point, I have not light cured. Okay, and I've probably got a good 4, 5, 6 minutes of working time here. So I clean off the gross excess with a cotton roll. And then the rest of the excess I get with a micro brush. And now I light cure those to place. And I clean them up. All right, I'm just looking at my time. And I got carried away, so I got to finish up kind of quickly. So the finishing up part, the gross excess of cement, I clean up before I light cure. After I light cure, fine diamonds and a number 12 scalpel blade at the margins. The number 12 scalpel blade interproximally, like we talked about for the temporaries. At the margins, I'm going to finish with a 30 fluted carbide burr to polish the margins and get those smooth. And then I follow up that polishing with a Profi cup and polishing paste until all the margins are smooth. Interproximally, I open up with a serrated metal strip like you're seeing here. See, the metal sides are polished, but the edge has these little metal teeth on it that will allow you to pass in between. There's a product called Series Saw by Denmat that I've found is really efficient to help me pass through here. Once I've passed through here, I check it with floss. Any place that snags, I use finishing strips to smooth that out until I pass in and out. Here we go. These are my finishing strips. All right. I use diamond finishing strips for really rough areas. Once I have those smoothed out, then the aluminum oxide finishing strips there until I can get floss in and out without shredding. The last thing we're doing is checking the occlusion and putting a final polish on the lingual side. And this is an 8-week post-op on the veneers on that patient, but you can see if we pay attention to the finishing and polishing that we get good, healthy tissue. So I apologize for running through the last 5 minutes there, but I wanted to get you through all the detail. I've probably got 2 minutes for question and answer. I'm going to hit those up. And then again, I gave my email address is right there on the screen. Hit me up with any other questions. One question, do you anesthetize during the prep and during the cementation? Yes, absolutely, every time. How big is the dot in the center of the tooth? 3 or 4 millimeters in diameter, maybe. Not very big. That's a good question. Do you put the centrals in first? Yes, I always put the centrals in first. Those are the building blocks everything goes on. So if the two centrals fit in and the symmetry looks good, I know I'm good to continue forward. But I always, every time, deliver the centrals first. This is an important one. Do you floss through before curing the veneers? Absolutely not. If you try to floss through the veneers before you've light cured the cement, you may dislodge the cement, or worse, dislodge the veneer and kind of suck in some crevicular fluid, which may contain blood, and that could cause staining at your margins. So flossing through before you cure may make your cleanup easier, but the potential problems are much greater. And I'd rather go through the process of using my serrated strip to separate the veneers and clean that way. But I never floss through before I cure the veneers. And folks, I have overextended my time. A ton of really good questions. I encourage you guys to email me. I will get back to you when I can, but I don't want to abuse your time. Thank you so much for joining me tonight, and I look forward to speaking to you sometime in the future on another program at Viva Learning. Thank you.